Hi everyone, it's me again, Pauline, clinical oncologist practicing in UMFC. Next, we're going to talk about current systemic therapy, mechanism of actions, and adverse event management. So these are the outlines that we will discuss in the lecture today. And the goal of this lecture is to understand the mechanism of action of various systemic therapy used in bladder cancer and its adverse event management. This is the same picture that I've used in the previous lecture. I know it's a lot to unpack, but in later lecture, I will classify it in a more organized manner so you can remember it better. In particular case, we will not discuss about vinflunin, as we don't commonly use this, and also sacituzumab govitecan, as it is not really available in Malaysia. So before understanding the treatment of cancer, we need to understand why cancer happens. So this hallmark cancer is really important for oncology training as it often appears in your molecular biology exams. So I suggest you spend a little time understanding this. Basically, these are the mechanisms that cancer cells adopt to escape cell death to continue to grow. Hence, by understanding these mechanisms, we can find targets that allow cell kill for cancer cells. So first, let's go into chemotherapy. I do understand that not all trainees here are oncology trainees. There are some urologists in the crowd as well. So I will not go in too much depth about all these treatments, but basically some simple concepts so that we can understand these agents that are being used more clearly. So the common regimes used are gemcitabine cisplatin, gemcitabine carboplatin, MVAC, or a combination of methotrexate, vinblastine, doxorubicin, and cisplatin, paclitaxel, and also docetaxel. To be honest, MVAC is not really commonly used as this regime can be quite toxic and hard to administer to patients. So I've classified these to 5 main groups, being anthracycline, vinca alkaloids, platinum, antimetabolites, and taxane. So by understanding these main classes, then you are able to understand the mechanism of action better. So first of all, let's move to platinum. So platinum examples are cisplatin, carboplatin, and oxaliplatin. It binds to the DNA structure here and forms cross-link and distorts the DNA structure. These disable the unwinding of the DNA structure, hence blocking DNA replication and transcription, leading to cell death. Next, antimetabolites including gemcitabine and methotrexate. So gemcitabine interferes with DNA synthesis. As you can see here, gemcitabine binds to the HENT1 structure. Again, don't worry too much about this. But as you can see here, the downstream pathway actually is important for nucleotide production. And nucleotide is an important building block for DNA synthesis. Hence, when there's no nucleotide, it leads to premature DNA chain termination and cell death. Next, for methotrexate, it is a dihydrofolate reductase inhibitor. And you can see the downstream pathway here is actually the purine synthesis. So by blocking this part of the mechanism, you actually reduce purine synthesis. And purine, as we know, is important for DNA building blocks. By depleting nucleotide precursor, DNA cannot be produced, hence leading to cell death. Next is that taxane. So taxane examples are paclitaxel and docetaxel. And also vinca alkaloids, as you can see here, also actually works at the microtubule structures. But in paclitaxel, as you can see in B here, it binds to the tubulin molecules. So it causes it to be unstable and also, not unstable, sorry, but unusually stable, causing it to be unable to depolymerize, hence causing the cells to be stuck in metaphase and unable to transition to anaphase, hence leading to cell death. This typically happens in G2M phase. Next, anthracycline, doxorubicin. Doxorubicin is a topoisomerase 2 inhibitor. And you can see here, topoisomerase actually helps to relax supercoil of DNA to facilitate replication and DNA synthesis. So doxorubicin binds to the topoisomerase 2 structure, causing the replication and synthesis process to be halt and leading to cell death as well. So the common adverse events that can be observed using chemotherapies, mainly high emesis risk, especially cisplatin combination regimes such as MVAC and also gemcitabine cisplatin. So prevention is better than cure. So identifying this highly emetic regime is important, so we can prescribe some anti-emetic, for example, 5-serotonin antagonist, dexamethasone, and K1 receptor antagonist. I suggest that you can check NCCN guidelines and before prescribing these highly emetic regimes to patients. Next is peripheral neuropathy, which can happen in regimes such as cisplatin and taxane. I would caution everyone that once neuropathy sets in, it is normally irreversible. Hence, recognizing this toxicity is important so that we can adjust our treatment according to it. So strategies that can be used are stopping the treatment completely, or we can reduce the dose, or switch to other less neurotoxic agents such as carboplatin. Some guidelines also suggest the use of duloxetine for painful neuropathy. Next, one very important adverse event is febrile neutropenia and sepsis. In febrile neutropenia and sepsis, key point is that time is of essence and is the most critical. We treat first and test second. So the most appropriate step is to start antibiotics immediately, preferably broad-spectrum antibiotics such as piperacillin, tazobactam. We do not wait for test results before treating. We treat first, then we investigate. We need to identify the source of infection and tests including chest x-rays, blood cultures, any test that could point you to the possible source of infection. Next, granulocytes colony stimulating factor or GCSF can be administered if indicated. We should monitor our patients closely, including vital signs, blood counts, renal and liver function, especially organ functions, and ICU backup if needed. Okay, next we will move into immunotherapy. If you can remember, one of the hallmark of cancer is actually avoiding immune destruction. And the common agents used here are anti-PD-L1, atezolizumab, avelumab, or anti-PD-1s, nivolumab, or pembrolizumab. And I think this is a good photo to illustrate escaping immune mechanisms and also how we reverse that. So on your left here, you can see the cancer cells actually express PD-L1 and our T cells have PD-1. So this actually allows the cancer cell to disguise themselves as friend and avoid cell kill by T cell. So by introducing anti-PD-1 and also anti-PD-L1, we can break this recognition and allow or remind our immune system that, hey, these are not my friends, hence releasing interference and leading to cell death. So the adverse events that are associated with immunotherapy, or mainly known as IRAE, immune-related adverse events, can be a wide range, as you can see in the photo on your left. It can involve any organ, because basically when we remind our immune system that, hey, these are not my friends, kill them, sometimes it can be overstimulated and target our own body as enemy and causes inflammation in basically any organ that you can think of. Hence, you can see the itis in every single organ, for example, encephalitis, hepatitis, pericarditis. So I like this table on your right because it actually is a good way to treat or mainly prevent and also manage IRAEs. First, prevention. For patients who have autoimmune conditions, for example, SLE, immunotherapy should be used with caution. Next, we should anticipate what will happen. With our knowledge of immunotherapy, we should have baseline checkups, including thyroid function, endocrine functions, and also during follow-ups, monitor these possible adverse events that can happen. Then we should detect it timely so that we can always act on it fast before it turns serious. Next, the treatment includes symptomatic treatment and also immunosuppressive therapy, which normally includes high-dose steroids, sometimes stronger immunosuppressive drugs such as rituximab can be administered. Next, it would be to monitor these patients closely about how long these symptoms actually resolve. And when they resolve, it should be a close discussion with the respective teams whether to reinitiate and also involve our patients in the decision making. So next will be targeted therapy. Targeted therapy that is discussed here mainly is erdafitinib. As you can see here, erdafitinib actually is an FGFR inhibitor, and FGFR downstream pathway actually activates the RAS pathway, PIK3 pathway, JAK pathway, which the downstream action is actually for tumor growth, survival, invasion, metastasis. So by inhibiting the upstream, we can actually inhibit the downstream process of this and leading to cell death as well. The common adverse events are hyperphosphatemia, ocular toxicity, and stomatitis. As of hyperphosphatemia, baseline bloods are important, and also monitoring of this should be done on weekly basis for the first month. The management includes dietary phosphate restriction, sometimes adding phosphate binders, and you would probably need to hold or reduce the dose if phosphate levels are more than 5.5 or when patient is symptomatic. Next is ocular toxicity, for example, CSR, central serous retinopathy. These patients will require baseline eye examination and also regular eye examination. And probably you need to refer to ophthalmology if you found this. And you may need to interrupt and also resume at lower dose or permanently discontinue based on the severity. Next, it will be stomatitis or mucositis. These are mainly supportive treatment. You have to ask patient to maintain good oral hygiene, use topical agents such as lignocaine wrist, avoid irritating food, and also you may need to again hold or dose reduce if it's more than grade 2. So next is antibody drug conjugate. So what is ADC? So ADC actually stands for A, antibody, D, drug, and then C, conjugate. So antibody is the part that binds to the specific targets on the cell, for example, Nectin-4, S of EV, and drug is actually the cytotoxic payload that is administered into the cell after binding to the antibody. And then these two agents are chemically linked or conjugated, hence the name ADC. So let's talk about enfortumab vedotin or EV. As we know, Nectin-4 is expressed widely in urothelial cancer cells, but low in normal tissues. So as you can see here, EV actually binds to the protein Nectin-4 and internalize and traffics to lysosome intracellularly, and then releases this toxic payload called MMAE. And this MMAE actually causes microtubule disruption and also cell cycle arrest, leading to apoptosis and cell death. So the adverse events, I think we previously have covered it briefly in the EVITA, but mainly the topmost three important ones is ocular toxicity, hyperglycemia, and peripheral neuropathy, which is the important criteria that I discussed in EVITA. So I suggest that you can pause this slide and read this closely. I will not go into it in detail. Next one that I would like to discuss is the rash, which can be quite troublesome in the use of EV. And sometimes we will need to use topical corticosteroids, antihistamine, sunscreens, and avoid irritants and moisturize the skin. But if severe as of other adverse events, you may need to stop with full or dose modification if indicated. So in summary, to understand the mechanism of all these drugs are very important as we can potentially identify the toxicity that is associated with it, and we can understand how actually cancer cells are being killed in these cases. Again, prevention is better than cure. So applying prophylactic measures is also very important as we can potentially prevent very disabling or life-threatening toxicities. Early recognition is key, but we can only recognize if we know what are the potential complications that we should watch out for. Lastly, we can involve other disciplines to co-manage. As we know, medicine is never one-man show. So by understanding these drugs in detail, I believe that we can adjust our treatment, tailor it based on our patients' comorbids and also treatment factors, and also disease factor, so that we can have a good balance between the toxicities and also disease control. Thank you.